You are going to get lots of clients coming to you with thoracic outlet syndrome stuff, which really just means a pinching of the nerves that come through your chest. Quite often this is the brachial plexus nerve that comes off your neck and goes down your arm. You'll get lots of people kind of complaining about numbness in their arms, things like that. That's super common. And that's kind of a thoracic outlet syndrome thing, or it could be. You're also going to get lots of people with TMJ syndrome. Everybody has a temporal mandibular joint. That is your jaw joint. So a lot of us go around, including myself, and I'll say, oh, you've got TMJ. What I really mean is you have TMJ syndrome or TMJ disorder. Everybody's got TMJ or you can't open your mouth. So, yes, Mr. Blygen, please.
With thoracic outlet syndrome, is there something that the client can do, like go get like an MRI or something like that to test for that? Or is that something that they just diagnose you with based on what you're feeling?
No, I mean, sometimes they do diagnose you with it just to send you back out of the doctor's office. But if they really want to know you have it, I don't know if an MRI will do it or not, but I'm not qualified to answer that part. But I do know one of the things that they will do is nerve testing, where they literally poke along the nerves and see where you can feel it and can't feel it and things like that. And they can narrow down which nerve it is and really see if it seems like it's pinched. I'm guessing an MRI could then say, yeah, it's pinched right there, but I don't know. But you're right. It can be diagnosed.
So like an EKG.
Yeah. Yeah.
Where they stick the little needles in the conductivity. Okay. Yeah, they did that for me.
Yeah.
With my arm, and they tried to tell me I had carpal tunnel.
Yeah.
But, I didn't have it.
Yeah, and if they don't do it,
just curious.
You're right. They're reading the pulse down, not the pulse, the electrical message down the nerve. But sometimes they get it wrong where it's pinched. You're right. Yeah. Okay. So anyway, so the reason I'm telling you this stuff about TMJ syndrome and about thoracic outlet syndrome is they're super duper common, especially in our society, because people kind of hunch up and clench up, and so lots of stuff happens with that, and you will have lots of clients like that, and they're really in need. Massage is really effective for this type of stuff, and I'm trying to remind you why the stuff you're about to learn is so important, so that you will care and want to learn it and remember it and all that good stuff. So let's take a look at Chapter 5, Head, Neck, and Face. There we go. Okay. So, wow, look at that. It's beautiful. Beautiful. We're going to talk about the sternocleidomastoid and scalenes and such today. Scalenes are actually on the side of your neck, and you can kind of see them in here. And we'll also later, not today, but tomorrow or the next day, learn about hyoids, which are these muscles up here and down here, these very tiny muscles that hook onto your hyoid bone. Okay. So, we all know about the SCM, which we call in this class the sternocleidomastoid, because after you leave here, you'll never say that again and you'll forget what it is. But the sternocleidomastoid literally attaches to your sternum and your clavicle and your mastoid process, right? If you look at your book, it says the origin is the manubrium, but the manubrium, if you guys will remember, is actually the sternum. It's just the top part of the sternum, and they call it the manubrium. So it hooks to the sternum, it hooks to the clavicle, the medial 1/3, so it's close to my neck, it's right in here, right? In fact, you can grab yours right now. I'm grabbing my sternocleidomastoid right now. You can grab them on clients too. I mean, I will actually try to roll the client's sternocleidomastoid over into my hands so I can massage it. But they're very easy to grab, especially when you don't have oil on your hand. And you'll know you grabbed it. You can feel it. It's probably a little sensitive. And then it goes up to the mastoid process, which is a bump on what bone? What bone is my mastoid process found on?
Temporalis.
Yes, thank you, sir. It's the mastoid process of the temporal bone. And I'm obsessed with this bone. You're going to hear me talk about it because it's got all sorts of really important features. It's got the mastoid process deep inside. It's got the styloid process, this little toothpick kind of thing coming off that bone. Your external auditory meatus, your ear hole, is in the temporal bone. This little bridge coming out here, the zygomatic process, is part of the temporal bone, and it goes to meet the mastoid process and make your cheekbone. So your temporal bone makes up your ear and half your cheekbone and this huge bump back here where all these important muscles attach to. And then there's stuff inside of your temporal bone, the styloid process, that actually hooks to your hyoid and things like that. So it's an extremely important bone. And the sternocleidomastoid can put a lot of pressure on it. So the sternocleidomastoid is part of your front fascial line. We haven't talked about this a lot yet, but we're going to. Your back fascial line meets your front fascial line right here at the mastoid process. What is the muscle coming from the back that hits the mastoid process and can actually argue with the sternocleidomastoid?
Scalenes capitis.
Actually, that's a very good answer. Yeah, sure. Scalenes capitis. Is there another muscle? You are absolutely right, by the way, sir.
And trapezius?
Trapezius.
Trapezius, no. No, I mean, by the way, trapezius can argue with it, but it doesn't insert into the mastoid process.
Is it the scalenes?
Nope, scalenes are on the side of the neck.
The
longissimus.
Thank you, Mr. Placencia. The longissimus. So, by the way, though, Mr. Blanchard's right. Scalenes capitis also goes up there too, but the longissimus goes from my butt up to my mastoid process, and then the sternocleidomastoid meets it here, and the longissimus can pull my neck back, and the sternocleidomastoid can pull it down, and they both kind of triangulate right there at that spot, so it's a high tension area because of that. So people with back troubles sometimes have sternocleidomastoid problems too, because they're kind of getting pulled here on this area. So do not underestimate the importance of this muscle. You know, you don't have single tension lines. They connect from front to back. And this is literally where the back fascial line goes to the front fascial line. Mr. Tate, please. You have a question?
What was that muscle again?
The longissimus, which is one of the spinal erectors, inserts into the mastoid process, and so does the sternocleidomastoid. And so does the scalenes capitis, by the way. So, actually, just to make a really quick point here, hold on. You guys haven't had one of my amazing drawings lately, so. So from a side view, that's a nose, so you know we're looking at the side. Whole neck here. This is me. You've got this mastoid process here. You've got the longissimus attaching there, and you've got the sternocleidomastoid attaching here. They make a triangle. And then if you look at a back view, there we go. If you look at a back view, oh geez, this person's much larger apparently. Look at a back view of the head. This is looking back here, right? The scalenes capitis creates a triangle here. We're going to learn when we look at fascial lines that there's lots of triangulation in your body because your body is trying to stand upright. So anything it puts over here, it's got to put something over here. Anything that puts up here, it's got to put something here. And what does it do all day long? When I get tension back here, it tries to pull me back here, and that's why we want to look at fronts and backs, right? We started out the whole class with this 8 months ago, 7 months ago, where we looked at like the scapula and the fact that yes, the rhomboids and the middle traps retract your scapula, but we also recognize that the serratus anterior and the pectoralis minor pull it forward. and that they can argue back and forth. And that really good massage therapists do what Miss Estes is doing right now. They release the pec minor because it's actually really a big part of releasing shoulders. And it doesn't kind of connect to the shoulder, it connects to the shoulder 100%. So anyway, that's why I'm making such a big deal about the mastoid process. Right? Cool, cool, cool. So that's 3 muscles that attach to the mastoid process right there. There's a deep one called the digastric we're going to learn about in just a couple days. That'll be the 4th one. Okay. Let me present again. Go back to this wonderful slideshow with pictures you can actually understand. And you should be able to find this muscle very easily if my computer will present. Bear with me, everybody. It really wants to show you this. Hold on. Try one more time. Come on. There we go. Okay. So that's the sternocleidomastoid. It's named after its origins and insertions. Right? Cool, cool, cool. And its main job is to create a flexion of the neck, right? It can also help to laterally flex the neck because it can pull to one side. It can also help to rotate the neck, right, to the opposite side. I don't care if you really remember the opposite side or whatever, but the fact is if this side closes down, I'll rotate to the opposite side. Cool. Because it can do this action, yes, Mr. Blygen, please.
Out of curiosity, how come this muscle doesn't have the word eye in it since it has 2 different heads? Because the heads are going to different muscles? I'm sorry, to different bones?
Yeah. Actually, no. You're giving far too much credit to the people that named the muscles. The problem is the same person didn't name all the muscles. So they all use different methods to name muscles. And because Latin is very common in medical stuff, they use Latin, but they all ran by a different system. This would be a great muscle to be called the biceps cervicis. You know, the 2-headed muscle in the cervical region. I think that'd be a great name for this. But that's not what the guy, whoever discovered this one, that's not what he called it. Yeah. That's even like where you get serratus anterior. Serratus anterior, serratus means saw-like. I mean, they didn't even use, like, it's just weird. People just, when they discover a muscle, they get to name them however they want. So whoever named this didn't pay attention to how other ones were named. Yeah, I like the idea of biceps, whatever. Biceps cervical or whatever. But that's why. And it makes anatomy a lot harder. Do you guys see what this hand is doing down here? One of the tricks to actually working the SCM, sternocleidomastoid, is to actually get it to roll over onto your hand. So you don't just try to grab it and pinch it. You actually kind of pull it down from here onto your finger, and then you can work it. That's what that person's doing. They're working it down onto their finger. And wiggle the head around, something like that. Super important muscle to massage. Also get down on the collarbone a little bit and massage its attachments. Don't poke them in the throat, because you can hear that doesn't sound very good. But get them here where it attaches. That is fine, and kind of rub some of those attachments too. And definitely get here. Definitely get the mastoid process. A lot of tension headaches come from this. Yeah. Sternal, clidal, mastoid. Okay. That takes us to something you're going to hear lots of therapists talk about these days, because they should. And that is the scalenes. You have an anterior, a middle, and a posterior scalene. And they all essentially hook to the transverse processes of your neck, depending on which scalene, from C1 all the way to C7. They hook to various transverse processes of your scalenes, all of them. And the transverse processes are the things that stick out of the sides of the vertebrae. So this muscle is found on the sides of the neck. It's not in back, it is not in front, it is truly lateral. Truly on the sides of the neck. And they have origins, or insertions, I don't care. But anyway, they have origins on the first and second rib. Origins on the first and second rib. The anterior and the middle one is the first rib, and the posterior one is the second rib. But so they hook your first two ribs to the sides of your neck to all your transverse processes. Yeah. What's really significant about this is, can somebody tell me what is poking its way out of, what nerve is poking its way out between the anterior and middle scalene? Thank you, Mr. Placencia.
Brachial plexus.
The brachial plexus, and that is the nerve that feeds most of your arm. And it comes out, by the way, along with the subclavian artery too, which feeds down your arm too. So some of that coldness that sometimes people get in their arm could be caused by this too. Again, I really want to warn you, it doesn't mean that every time somebody has numbness in their fingers or hands that their nerves are pinched there at the scalenes, but it's not a bad place to start working. Because between the anterior and the middle scalene, your brachial plexus can get pinched. And that is one of the places that you can have thoracic outlet syndrome. The other place you can get it is after it comes out of the scalenes, brachial plexus goes underneath the collarbone. You guys remember the subclavius, that little bone muscle that pulled down the collarbone? If the collarbone's pulled down too hard, it can get pinched there. It then runs under the pec minor and get pinched there too. So it's got three great places to get pinched before it starts shooting down the arm. So this would be a great area to work the side of the neck, literally try to trace out the clavicle and work the pec minor for somebody with possible thoracic outlet syndrome. And your job, by the way, is not to diagnose. Your job is to make educated guesses and try stuff based on those educated guesses to do intelligent work. But your job is actually not to diagnose. In fact, you're not allowed to. You can't tell somebody, I'm positive this is thoracic outlet syndrome. You don't know. Even if they get better, you don't know. But these are really good places. When somebody comes in and says, yeah, my arm, I get a lot of numbness and tingling down it, and they look a little bit hunched up too already and stuff, and I'm going to hit scalenes. I'm going to hit all around the clavicle to try to open that up and actually literally get my fingers under it and get around it. And I'm going to hit pec minor a lot too. That's going to be some of my first stuff that I do. Then I'm going to work down their whole arm because who knows what's going on there. But that's some of my first stuff to do, and that's the scalenes. So the scalenes are very likely culprits of pinching the brachial plexus. Of course, so is pec minor, but cool. So anterior scalene, the one in front that we really care about, hooks to the transverse processes of C3, C4, C5, C6. The next scalene that we're going to get to grabs onto even more. It's 2 through 7. That's the middle scalene. It goes to, middle scalene goes to the first rib too, but it grabs onto the transverse processes, these things that stick out of the side of your neck, of C2 through C7. And then the posterior scalene is actually quite tiny. And it hooks onto just C6 and C7 and the second rib. But I really care about the first two. And by the way, when I'm massaging somebody, I'm just massaging all of them. I'm not trying to be that picky. I'm trying to find the transverse processes of their neck and rub around those. Especially, by the way, right behind the transverse processes. Can anybody see from this thing why I might be trying to rub right behind the transverse processes?
Is that where the muscles are located?
Yeah, they're really nitpicky here, but this, yes. So the middle and posterior scalenes, if these are my transverse processes, they don't hook on the sides, they actually hook on the behind them. The anterior scalene hooks on in front a little bit. And so, if anything, try to actually trace the transverse processes, but especially behind. But you're trying to find the transverse processes, bring these strange little things to get out, and kind of get your fingers on both sides of them and stroke them there. You're absolutely right, sir. To loosen them up. And you can feed them all the way down to the neck. In fact, if you guys try to reach down under your collarbone right now, you're going to hit some stuff. Guess what you're hitting? If you are on the side of your neck here and you try to kind of reach down into your collarbone, you're going to kind of run into some soft tissue. That's your scalenes heading towards your first rib and second rib. This is my scalenes I'm running into here. And if you lift up the client's collarbone, you can actually get in deeper into them because you can start digging down underneath the collarbone. This is some of Miss Mejia's favorite work. She likes to lift the collarbone way up, get her fingers right underneath there, scoop in there, grab. Yeah. If you do it to yourself, sometimes you end up tensing up, but you really can have them on the table. Lift up the collarbone and get way underneath in there. Yeah. Mr. Blige.
How do we avoid hitting the subclavian artery and brachial plexus while we're doing it?
As long as they're not getting any zinging. Again, you're looking for. I don't care if you hit the artery. To be honest with you, it's very strong, and you're not going to be pushing that hard. It's a pretty sensitive area. But as long as they aren't getting referred pain down their arm, more so than they came in with, you're fine. If they're getting referred pain down their arm, just slightly move your fingers because you're probably pinching the nerve. But that's how you'd know. If they're getting local pain, like right here where you're digging, assuming they can handle it, that's fine. That's what you want, really. Not that you want to hurt your client, but that means you're working on the muscle and you're not pinching the nerve. Usually you're pinching the nerve when it starts sending referred pain, shooting down their arm or whatever. That's when you have to move your hand a little bit. And by a little bit, I'm talking like beep, tiny little half a centimeter is usually enough to kind of get you off that brachial plexus. The subclavian artery is really tough, and as long as you're not, I think you do damage to other things before you did damage to it. I don't think you have to worry about it. Good questions. Okay, so we've learned about the sternocleidomastoid, right? And the scalenes, anterior, middle, posterior. Yeah. And I thought we had, oh, we do, good. There's a muscle called the platysma, and you probably massage on people all the time and don't know about it. In some ways, it's a facial expression muscle. It does help to lower to depress your mandible, open your jaw. And I'll show you what here. Hold on. And it's very easy to see yours. If you just do this, that is my platysma. And I used to do this for my kids when they were little. Kind of lizard dad. They loved it. Okay. You guys aren't kids, so you don't get it. Anyway, that's your platysma because it's in your surface skin. It actually doesn't really have an origin on bone. It's actually in my pectoralis tissue down here in fascia and runs up, really, really thin muscle, running up, weaving through the fascia itself and hooking on to the sides of my jaw. It does get tense, by the way, and it does help loosen people's necks up in general to rub it, but you're going to rub it. Yes, it is superficial to all the other muscles, sir. Yes. Yeah, especially in the pectoral region, but yes. The answer is yes, yes, yes. I think it's, yeah. I was trying to think of even the face, but yes, it's superficial to all of them, sir. Definitely all the structural muscles. Anyway, so your normal strokes that you're doing, where you're doing big strokes and stuff like that, hit the platysma, but it's another reason to tie the chest into the neck. Right? I hope you guys are overlapping in your massage and tying stuff together. It's okay to run over, yes. Yeah, when we do an arm, we really do an arm and a little bit of chest. When we do a chest, we do a chest and a little bit of arm. When we do chest, a chest, a little bit of neck, that kind of thing. Cool. All right, that's your platysma. It's kind of your lizard muscle. All that good stuff. Very attractive. Very attractive. And last but not least, and this is kind of interesting. On top of your head, you've got an aponeurosis. Oh, sorry, Miss Mejia. Yes.
You don't have the slideshow up. I don't know if you want to have that.
I you want to have the slide show up. I'm really glad you said something. Let's see if we can pull this off. Okay. Let's go back too. I don't even know if you guys, this is the Platysma. And let's go to the Occipitofrontalis. Yes, Ms. Sarno, please talk to me.
Yeah, in occipital and frontalis, one muscle across to the back, or two. I just feel like there's in the big cheek cover that. I think, oh, maybe I think one muscle and like a trapezius. We still have upper trapezius, middle trapezius, lower trapezius. And this should be one sheet of the muscle or not. I don't know.
I'm not laughing at you. I'm laughing with you because what Ms. Sarno brought up is, I'm just shocked she brought it up. This is something that anatomy people and massage therapists argue about all the time. And what Ms. Sarno is asking is, you have a frontalis muscle and an occipitalis muscle. Some people refer to them as two separate muscles. Some refer to them as the occipitofrontalis, as though it's a two-bellied muscle. Ms. Sarno is arguing that it should be one muscle, just like the trapezius is really three different fibers going three different directions, but we call it the trapezius. I am 100% in agreement with you, Ms. Sarno. I think it's one muscle. I talk about it as one muscle. Plus, for my massage, it's one muscle. But it's funny, some people like to talk about it like two separate muscles, and it's a silly argument either way, but we love to argue about it. But your argument, I think, is a really good one. I agree with you for that reason. We're also going to later learn a hyoid muscle called the digastric, and it literally has two muscle bellies. It's got like a tendon, a muscle belly, a tendon, a muscle belly, and a tendon. And it's one muscle, so why wouldn't this be one muscle? I agree. I agree. One muscle. So in this class, at least, it's the occipitofrontalis. One muscle, two bellies. So, they both have an origin, these muscles, on the Gallia aponeurotica, which is just an aponeuroses on your head. What's an aponeuroses? Yeah, that's right, Miss Mejia. What's an aponeuroses?
The sheet-like fascia?
Yes. Miss Mejia, could you tell me two other very prominent aponeuroses you have in your body?
The thoracolumbar aponeurosis.
That's probably the most important one.
The one that's on your ankle that I don't remember the name.
Oh, you're thinking of retinaculum there.
Oh, okay. I don't know the other one.
The other one is to balance out the thoracolumbar aponeuroses, and it's the abdominal aponeuroses.
Oh, okay.
That's why when you see pictures of tummy stuff, they only get that white stuff there. That's the aponeuroses. So you've got an abdominal aponeuroses and a thoracolumbar aponeuroses, kind of one on the front of your body, one on the back, and you've got one on the top of your head, the Gallia aponeuroses or Gallia aponeurotica. I don't care which way you say it, although I think aponeurotica is kind of fun to say, so that's what I say. So this Gallia aponeurotica is really like a shower cap on your head, and you've got a very flat muscle back here called the occipitalis, and a flat muscle up here called the frontalis. And the frontalis actually hooks into the skin right above your eyebrows, and the occipitalis actually hooks into the nuchal line back here, the superior nuchal line. And the Gallia aponeurotica, believe it or not, even though it can move, is kind of sewn into your skull too, but it can move. But it can't slide right off. And we refer to these just like the iliopsoas, which is really two muscles. We refer to this as the occipitofrontalis. I agree with you, Ms. Sarno, it's really one muscle as far as I'm concerned. Yes, by the way, is that what surgeons mess with when they're doing a facelift? It is one of the things they mess with when doing a facelift. They also quite often, Mr. Blygen, tuck behind the ears so they actually pull back the face. But yes, sometimes they raise up the face too, and yes, it is what they would mess with. Absolutely. Yeah. It always freaks me out a little bit. Like, I'm not against doing it, but because it kind of moves people's features around. I'm like, nobody looks like that, you know? Anyway, so, By the way, there's a lot of research to suggest that massaging people's faces helps reduce wrinkles and keep them young looking and all that kind of stuff too. So, and you don't even have to cut into them. Anyway, what's kind of interesting about the occipitofrontalis is that a lot of these muscles back here, like my trapezius and my longissimus and my splenius capitis and my semispinalis capitis and my splenius cervicis and all that stuff, they attach in this same fascia back here. And so sometimes when people are really tense, you will actually watch them. They will come in and they kind of look surprised. And then at the end of their massage, you've loosened up their shoulders so much that their eyebrows drop back down. Because they literally were having their gallia aponeurotica pulled from the back. It's kind of cool. So it is a structural muscle. Not so much because the occipitofrontalis changes your structure, but because of the stuff that attaches to the back of your head. Remember, your shoulders hang off the back of your head and neck. So there's actually quite a bit of tension there, and you will sometimes see people literally kind of pulled back there, and then after the massage, their face looks normal again. That means you've done a really good job. And that's the occipital frontalis. Yeah. So I think the most important thing, yes, it helps you raise your eyebrows and all that kind of stuff, but really the significance of this is they anchor to the back of your head. Yes. Ms. Sarno, please, talk to me.
If that's the muscle on the frontalis and occipital, and like when they have migraine, and they go on like here.
Yeah. I don't, are you asking me or telling me?
No, it's, I ask you, a lot of the people, that will cause migraine to the...
Yeah. I don't know if it causes migraines, but it causes headaches, yes. And yes, you can literally get to where this thing is being pulled on so heavily that it really just feels like your head's on too tight, yes. And we don't just massage this, actually, really what we do is focus on the stuff back here. Seems to really loosen up the occipitofrontalis, yeah. But I would rub this whole thing, yeah, to loosen all that up. And you're right, I think it causes headaches most definitely. It puts pressure on your skull, yes. And then it spreads to other things. Because you've got other muscles in here that also insert into the gallia aponeurosis that we're going to learn about, like your temporalis is right in this area too, and they all start pulling on this thing and they start fighting and it's a problem, yes. Yeah, super important for headache stuff, I agree. Mr. Blygen, you had your hand raised too, sir.
Yes, so with the occipitofrontalis, did we agree that that's one muscle or two?
Well, Ms. Sarno and I agree it's one muscle. You don't have to agree.
Okay. Well, I was asking, and I'm not tripping about it, but like we had that question last night on the homework, and I got 1 point off, but I said it was one muscle, and I explained my reason, and then it was graded, and it said that it's two muscles.
Oh.
So I just want to make sure moving forward that I'm like on the same page with whatever the standard is.
So it wasn't automatically graded, right? Mr. Ibarra went in there and graded it, I suspect?
Yeah, there's a comment in there that says that it's two muscles with, and I think that goes back to what you said about therapists having disagreements about it.
Yeah, and by the way, I don't think you should be penalized because Mr. Ibarra and I don't agree, but I'm laughing because that's exactly, it's the age-old argument. And so he is in the two muscle camp, I am in the one muscle camp with Miss Sarno though. And that's the camp you want to be in because that's where all the cool people are. So anyway, but yeah, that's what happened, sir. I think you should go back and be like, Tapscott says it's one muscle. I want my point back. Yeah. Yeah. Okay. But anyway, yes, you're right. Because, by the way, sir, because there is no correct answer to that, in my opinion. Like, you can argue both ways. It's just a silly it's what massage therapists do at cocktail parties. They argue about stuff like this for fun, and we think it's cool, and it's not. But what's really cool is you got a gallia aponeurotica, and there's all these muscles pulling on it, and they can cause headaches and things like that, and all this can tie into TMJ later, TMJ syndrome too. So we do care. This is part of the reason we think neck and shoulder tension ends up affecting your jaw, is because of the gallia aponeurotica. which is composed of two bellied muscle, the frontalis and the occipitalis, but later we're going to learn there's other muscles that are woven into it anyway. This whole area is just a big weave of stuff weaving into the fascia here. Yeah. But yeah, sorry, sir, you got caught in the crossfire. Okay, everybody, I think it's a good place to take a break. That's all the new muscles for today. Let's take a break. I'm getting some nods out there. It's a good time to do this. We will be back at 4:43. 4:43. Thank you.